This is the 8th in the series of ECG tutorial, how to read the ECG basic principles from Dr. Nasmani in the YouTube /ACPGMAT. Hope you are enjoying these sessions and expect your cooperation. Please visit the channel and go through the sessions and give me the feedback. So I'm continuing with the analysis of ECG on myocardial infarction. Today something about ST segment elevation and the remaining parts and a few exercise. Now let us see what is this ST segment elevation. Some part was discussed already, and in some of the video sessions which are coming I will go to the basic analysis of the various parts of ECG recording. The causes of ST segment elevation, acute myocardial infarction is one most common thing which already told. Then high takeoff, then benign early repolarization, left bundle branch block also may show ST segment elevation. Left ventricular hypertrophy is another condition. Then ventricular aneurysm, one example was already shown to you previously. Then coronary artery vasospasm and Prince-Metal's angina, and some of the drugs are notorious for that. Pericarditis, of course, sometimes missed. Brugada syndrome, about which I already told in the previous video, and subarachnoid hemorrhage. In fact, it is very funny to see a CNS condition causing an ECG change. Now, what is this high takeoff? Care is required when interpreting ST segment elevation in right sided chest leads, as the ST segment, particularly in lead V2 and V3, tend to be upsloping rather than flat. Isolated ST segment elevation in V2 and V3 should be interpreted with caution. This is the exercise for you to see and make a comment and diagnosis. Yes, what does it show? That shows benign early repolarization. Of course, all these ECG recordings should be provided with clinical details also. Now, benign early repolarization is a degree of ST segment elevation often present in healthy individuals, especially in young adult and in African descent. This ST segment elevation is most commonly seen in the precordial leads and is often most marked in lead V4. It is usually subtle but can sometimes be pronounced and can easily be mistaken for pathological ST segment elevation. Benign early repolarization can be recognized by its characteristic electrocardiographic features. There is elevation of the J point above the isoelectric line with a high takeoff of the ST segment, a distinct notch at the junction of the R wave and S wave, the J point, an upward concavity of the ST segment, and symmetrical upright T waves often of large amplitude. Antecedent myocardial infarction. The ST segment elevation associated with acute infarction usually resolves within 2 weeks of the acute event, but it may persist indefinitely, especially when associated with the anterior myocardial infarction. In these patients, a diagnosis of left ventricular aneurysm should be considered. Care should be taken when interpreting the ECG within 2 weeks of an acute event, and a comparison with the old ECG may be useful. So always tell the patients when ECG is taken, please keep the ECG. Cut these papers, the long strip, to small ECG leads, paste it to an A4 size paper and take photostat, because the ECG recording will fade over a few weeks because it is not ink. Otherwise you may not get the old recordings. Acute pericarditis is commonly mistaken for acute myocardial infarction, as both cause chest pain and ST segment elevation. In pericarditis, however, The ST segment elevation is diffuse rather than localized, often being present in all leads except AVR and V1. The elevated ST segments are concave upwards rather than convex upwards, as seen in acute infarction. Elevated ST segments are concave upwards rather than convex upwards, as seen in acute infarction in pericarditis. Depression of the PR segment may also be seen. ST segment elevation in pericarditis is thought to be due to the associated subepicardial myocarditis. The zone of injured tissue causes abnormal ST vectors, and the end result is that leads facing the epicardial surface record ST segment elevation, whereas those facing the ventricular cavity, that is lead AVR and V1, record ST segment depression. The absence of widespread reciprocal change, the presence of PR segment depression, and the absence of Q wave may be helpful in distinguishing the pericarditis from acute myocardial infarction. Once more I will say, absence of widespread reciprocal change, presence of PR segment depression, and absence of Q wave helps in distinguishing pericarditis from acute myocardial infarction. Other causes of ST segment elevation, the characteristic feature of left ventricular hypertrophy, are also often misinterpreted as being caused by acute ischemia. ST segment elevation in pericardial lead is a feature of left ventricular hypertrophy and is due to secondary repolarization abnormalities. In this exercise number 4, I am showing a 57-year-old man with old MI and a left ventricular aneurysm. Identify the abnormality. That shows the persistent ST segment elevation in anterior chest leads in association with the left ventricular aneurysm. This can be diagnosed only if you had an old ECG also, about which I gave the clue in the question. This exercise number 5 shows an 18-year-old boy with pain in chest for 2 days and fever for 2 days. What's the finding? That shows the acute pericarditis with widespread ST segment elevation and PR segment depression. See the lead 2. ST segment abnormalities are seen in association with intracranial hemorrhage, especially subarachnoid hemorrhage. ST segment elevation or depression may be seen. Why in subarachnoid hemorrhage? It is because of altered autonomic tone affecting the duration of ventricular repolarization, which produces these changes. The subarachnoid hemorrhage affects the autonomic tone, which in turn causes ventricular repolarization, and that produces the ST segment abnormality in subarachnoid hemorrhage. What is this Prince-Mettels angina or vasospastic angina? It is associated with ST segment elevation. As the changes are due to coronary artery spasm rather than acute infarction, they may be completely reversible if treated promptly. ST segment abnormalities may be seen in association with the cocaine use and are probably due to combination of vasospasm and thrombosis. This exercise number 6 shows a 21-year-old laborer who uses pan masala and is brought to the casualty with chest pain and chest discomfort. What's your diagnosis? That is the reversible ST segment elevation associated with coronary artery spasm due to the cocaine present in the pan masala. After around 6 hours, he reverted to normal. ECG reverted to normal. That's exercise number 7, showing a 48-year-old person with hypertension for last 1 year. The apex beat was forceful, and his BP at the time of admission to casualty was 160/100. And history shows that he was on irregular treatment for hypertension. What's the ECG finding? That was ST segment elevation in lead V1 to V3 with left ventricular hypertrophy, which was due to hypertension. So that was the presentation from Dr. N.S. Mani regarding the ECG tutorial. Please visit my site www.youtube.com/ACEPGMed. If you got Facebook account, please make friends with www.facebook.com/ACEPGMed. Thank you.